Inflammatory bowel disease. General features. In routine clinical practice, the first concern is always whether the patient is well, unwell or extremely unwell, but patients who are acutely unwell are not likely to appear in a PACES examination. Important issues to comment on before proceeding to examination of the abdomen itself include the following. Nutritional status. Does the patient look well nourished? If given the opportunity to ask, say that you would like to know his weight, height, and BMI. Hands, clubbing, leukonychia. Eyes, anemia is a frequent complication of Crohn's disease and iritis and association. Mouth, aphthous ulceration. Legs, erythema nodosum, peripheral edema due to hypoproteinemia. Features of chronic liver disease. Primary sclerosing cholangitis, PSC, may complicate ulcerative colitis or Crohn's disease. Abdominal examination. External examination of the abdomen may be unremarkable, but look and palpate carefully for the following. Scars. About 80% of patients with Crohn's disease and 20% of those with ulcerative colitis undergo abdominal surgery over a lifetime. Palpable bowel. A thickened fibrosed segment of sigmoid colon may be felt in ulcerative colitis. Crohn's disease, also ileocecal tuberculosis, may cause an ill-defined tender mass in the right iliac fossa. Rectal examination. This is mandatory in clinical practice and should be commented on, although not performed, in the setting of the PACES examination. Features to look for would include signs of excoriation at the anal verge, may result from excess secretions. Ulceration, fissuring, and scarring, signs of anorectal involvement. Blood and pus, indicative of active proctitis or colitis. Further discussion. Abdominal examination may be completely normal in cases of inflammatory bowel disease, but it is likely that at least some features of the general or specific examination will be abnormal in a patient appearing in PACES, although a patient with no abnormal physical signs can be included. If you could feel a mass, what is the differential diagnosis of the findings? Could colorectal neoplasia mimic inflammatory bowel disease? As cancer can complicate long-standing active colitis, this is an important practical question, and the presence of a mass would require investigation with CT and/or colonoscopy. If this man presented with bloody diarrhea, how would you manage him?